Welcome back, everyone. We're going to continue down the obstetric series with discussing the complications of childbirth. As mentioned several times before, childbirth is a normal process and is usually an unremarkable event that passes and transitions completely uneventful, and most of the time complications don't arise. However, being pre-hospital emergency medicine providers, we do need to be prepared and aware for some of the common complications that are associated with childbirth and how to address each of those. Let's start with a premature rupture of membranes, and this is when the amniotic sac ruptures or opens more than a few hours before labor. The sac may seal itself off. Often labor will begin within 48 hours, but if the pregnancy is not near term, then there's a risk of infection that can exist here. Preterm labor is labor that begins after the 20th week, but before the 37th week of pregnancy. The patient may be admitted to the hospital for bed rest, medication, and monitoring. Fetal distress is caused by a number of conditions. It's difficult to assess in the field as we just generally don't have the equipment to monitor fetal heart rate and such. Most women will know if fetal movement has slowed or stopped, and our job in this case is to provide transport and supportive care. A uterine rupture occurs typically during labor. Signs and symptoms include weakness, dizziness, and thirst. Initially, the contractions will be strong, but then there may be a cessation of contraction strength, or they may lessen. The patient will present with signs of shock, and for this case, we need to provide rapid transport to a receiving facility and treat for hypovolemic shock. Precipitous labor and birth, this is when the entire labor time and birth time is less than 3 hours. Chances increase in a woman that has had more children. Contractions are usually more intense, and assess the woman for a woman post-delivery for tears and bleeding during a precipitous labor. Postterm pregnancy is when the fetus has not been born after 42 weeks. Causes are unknown. The situation is high risk because the fetus can become malnourished, and there's an increased chance of meconium aspiration during delivery. Meconium is the first stool that the fetus passes. It's usually odorless, and it's a greenish or black color with a tar-like consistency. It may be expelled into the amniotic fluid and can be a cause for chemical pneumonia within the newborn. So this should be one of the things that you look for during the birthing process. Fetal macrosomia is when the fetus weighs more than 4,500 grams. Treatment should focus on support and rapid transport. If there is a field delivery, encourage breastfeeding from the mother and check the newborn's glucose levels, as maternal or gestational diabetes is always of a concern with large birth weights. Multiple gestation, prepare for more than one resuscitation, right? Consider the possibilities of multiples if the first newborn is really small or the abdomen is still relatively large after the childbirth. The second newborn is usually born within 45 minutes or so of the first. The procedure for multiple gestation and multiple birth is the same for a single birth. You're going to check if there are 1 or 2 cords coming out of the placenta when it delivers. And you'll need to record the time of birth and the APGAR score for both newborns. Identify the first newborn delivered as baby A, and subsequent would be baby B, and so forth. Intrauterine fetal death, this is where the fetus died in the uterus before labor. Care is going to focus on maternal care. And the actual cause is difficult to determine, but you can see here's a table that expresses some of the causes of fetal death, with the most common being pregnancy-induced hypertension. Labor can occur up to 2 weeks or longer after the fetal death. Labor usually progresses normally. Do not attempt to resuscitate an obviously dead fetus. Amniotic fluid embolism is when amniotic fluid enters into the woman's pulmonary circulation through the placenta. This results in an allergic reaction type response, and signs and symptoms can include things like respiratory distress, hypotension, cyanosis, and seizures. If the patient survives the initial reaction, they'll likely develop coagulopathies, and this is where disseminated intravascular coagulopathy is of concern. Treatment includes supporting respiratory and circulatory system and providing rapid transport to a receiving facility. Hydroamnios is where there's too much amniotic fluid. This is usually detected by ultrasound prior to delivery. Patients are at risk for prolapsed cord, abruptio placenta, as well as postpartum hemorrhage. Cephalopelvic disproportion is where the head of the fetus is larger than the pelvis itself. This is usually a stasis in the childbirth process and requires a cesarean section. It can also be a cause for massive hemorrhage and significant postpartum complications. So if delivery is not progressing in what would otherwise you would have assessed as an imminent delivery, you need to consider cephalopelvic disproportion and engage in transport to an appropriate facility. Cephalic presentation, this is where the newborn's head is overly extended coming out of the birth canal and presenting with a face presentation at the vaginal opening. This can be classified as brow presentation, and that's where the upper portion of the face is presenting occiput or posterior, so the back of the head, or military presentation. If the newborn's head can't be externally rotated or delivery can't be completed, then you would need to support the woman and fetus and provide rapid transport to a receiving facility. There are different types of breech presentation, and each of these indicates a position presenting at the vaginal opening or through the birth canal other than the top of the baby's head. We've got frank breech, which is where the buttocks present, a complete breech, or a footling breech where a foot may present. If the buttocks are presenting and delivery is imminent, position the woman with her buttocks at the edge of the bed or stretcher and legs flexed. This will allow the newborn's buttocks and trunk to deliver spontaneously. Once the legs are clear, you'll want to support the body and lower the newborn slightly. For breech presentations, when the hairline is spotted, grasp the newborn's ankles and lift upward. If the head doesn't deliver within 3 minutes or so, the newborn may suffocate. Do not try to forcibly pull the newborn out. And we'll go over some of these presentation procedures in lab so you can get some experience with how to support and hold baby during this birthing process. Other presentations are rare, like footling breech or transverse presentations, but it's not abnormal to experience them. Do not attempt delivery in the field if you're getting things like footling breech or a hand breech or an arm breech, as the physiologic structure of the birth canal isn't really built to accommodate delivery in that manner. So if you have a footling breech or a shoulder breech or arm breech, then you may want to consider rapid transport and consultation with the receiving facility on best practices for how to proceed. Shoulder dystocia is difficulty in delivering the shoulder for the infant and can be a significant cause of fetal injury and is relatively manageable in the prehospital world. If the shoulders can't clear the birth canal, then the fetus can't breathe. Remember that maternal and fetal circulation have been separated at this point. And a major concern for the fetus is the brachial plexus injury that can occur by exerting pressure on that shoulder. McRoberts maneuver is the technique utilized to help facilitate birth during shoulder dystocia. And you're going to first take a hold of the patient's foot, the mom's foot, and you're going to flex the legs tightly up to the abdomen. And this usually requires more than one person to facilitate the process. So you can engage family members or dad on scene or your partner to help push the feet upward, the knees upward toward the chest. So you're bringing the knees up toward the abdomen and rolling the buttocks upward. You may also need to apply slight pressure on the lower abdomen while pulling the legs back, and that helps push the shoulder underneath the symphysis pubis, which is where the catch for the shoulder is during shoulder dystocia. Nuchal cord is when the cord becomes wrapped around the newborn's neck during delivery. It can cause fetal heart rate to slow. This is a relatively common occurrence in delivery of a newborn, but is also relatively easy fix, and most of the time ends up being a benign process. You want to slide a gloved finger under the cord and gently attempt to slip it over the shoulder and over the head. So in this image you can see here, you can slide your finger underneath the cord and pull it from the back of the baby's head forward. That will unwrap that loop of the cord, and usually that will allow the rest of the cord to fall by the wayside, and you can successfully deliver baby. If you're unsuccessful and you can't, or if there's a significant barrier to getting that cord over the neck, you can always clamp and cut the cord here. Just make sure that you're able to first suction the airway and prepare for fetal ventilation if needed, and make sure that delivery can proceed unencumbered once you cut the cord. A prolapsed umbilical cord is where the cord emerges before the fetus. This can be problematic as it can shut off oxygenated blood supply from the placenta and it can lead to fetal asphyxia. For this case, keep the woman supine and the hips elevated, administer O2 to mom, and then have the woman pant with each contraction. Gently push the presenting part back up into the vagina until there no longer presses on the cord. The other option is to have your partner or another paramedic on scene can slide a glove finger and create a space around the cord so the circulation can move through the cord. Maintain that position and transport emergent to the hospital. For a uterine inversion, this is when the placenta fails to detach and properly from the uterine wall when it's expelled. The uterus turns inside out as a result. The severity for this is graded by how much the uterus has reversed itself, whether it's an incomplete inversion or a total inversion. The condition is painful and can rapidly lead to shock as the internal bleeding surfaces of the uterus are now external, and any contractions that are occurring from the release of oxytocin are exsanguinating blood out and not contracting and applying pressure within itself. Keep the patient recumbent. For this, administer O2, start 2 IV lines, and do not attempt to remove the placenta if it's still attached to the uterus. For paramedic level providers, you're going to carefully monitor vital signs, and you can consider oxytocin to control hemorrhage. Again, the problem being here is that if the uterus is completely inverted, you're essentially going to exsanguinate the patient by contracting that uterus. Paramedics can make one attempt to replace the uterus in the event that the patient is in a state of hemorrhagic shock. Elsewise, moist dressing if bleeding is controlled. Postpartum hemorrhage can be either early or late hemorrhage. Early bleeding generally occurs within 24 hours of delivery, while we classify the late as 24 hours to 6 weeks after delivery. Blood loss that exceeds 500 milliliters during the first 24 hours after birth is considered excessive, and we would expect to see about 500 milliliters during the normal birthing process. Causes of postpartum hemorrhage include things like lacerations, prolonged labor, or multiple baby delivery, retained products of conception, multiple pregnancies, placenta previa, or full bladder. Continue a uterine massage. Encourage the woman to breastfeed. Remember that helps release the oxytocin and contract down the uterus. Transport immediately, and then treat for hypovolemia and shock if the patient presents as such. So for EMT basic level care, that's going to be oxygenation and warming the patient. AEMTs and paramedics, you may consider fluid resuscitation for these. Do not, under any circumstances, pack the vagina with dressings or gauze or agents to attempt to stop the hemorrhage. Pulmonary emboli is frequently caused by a clot arising from pelvic circulation. This can be things like amniotic emboli, pregnancy-related venous thrombi, or water emboli. If you suspect a patient is experiencing a pulmonary embolus postpartum, presentation can include things like sudden dyspnea, tachycardia, atrial fibrillation, or an irregular atrial heart rate, hypotension, sharp, sudden chest or abdominal pain, as well as syncope. We would treat this just as any other pulmonary emboli, high flow oxygen to patients, hypoxic, circulatory support, and emergent transport. The last two conditions we want to talk about are postpartum related to mom. Postpartum depression is experienced by at least 1 in 9 women, and it can appear up to a year after birth. Signs and symptoms are similar to other types of depression, but they also can include things like anger directed toward the infant, little or no interest in the infant, or thoughts of harming one's self or the infant. And this can lead to cases of malnutrition for infants as well. And this is not necessarily an intentional neglect or abuse of the child, but is a byproduct of the hormone changes that occur post-pregnancy and during pregnancy. The other to note is a condition called postpartum psychosis. And postpartum psychosis is a more virulent and aggressive form of postpartum depression that can lead to delusions, can lead to suicidal ideations, homicidal ideations, and these again are not these are not intentional thoughts. These are thoughts that are generally derived from the biochemical changes that are taking place at the hormonal level postpartum and can be very, very serious and very deleterious. It's important that we recognize the potential for these in the postpartum patient. And while you may not see these incidences occur directly after birth, where you would most likely see is if you were called to the home of a patient who was recently born. And so you need to be diligent in your assessment of mental health disorders and potential problems that can arise in postpartum patients to, one, not only best treat your patient, but also to best treat the newborn as well.